In season 2 of the Best of Health podcast, I am shining a spotlight on all of the life stages of women's health, from menarche to post-menopause. Topics covered will range literally from head to toe, addressing migraines to vaginal health and everything in between. My conversations are going to be with leading experts in their field, and we will tap into a deep well of knowledge and uncover an array of clinical pearls which promise to be an illuminating and helpful support to your personal health journey. So grab a cuppa and join me this autumn for the Best of Health Season 2, Women's Health Uncovered. Welcome back to the Best of Health podcast Season 2, and today I am thrilled to have back with us Dr Nicky Keay, who is a medical doctor, and she has 30 years experience both clinically and in the research area of endocrinology, and very specifically in an area of endocrinology which is exercise endocrinology, which is a niche market. But there are many individuals and women who need this sort of very specific understanding of and how this relates to our hormones. Nicky is also Chief Medical Officer with a hormone company called Forth with Life, which we fondly call Forth. And they are a comprehensive blood testing company with a particular focus looking at the lens of female hormones and endocrinology. And for anyone listening that is interested in hormones, female health, and exercise, this episode is going to absolutely blow your mind. So welcome back, Nicky, to the podcast. Absolutely thrilled to have you.
No, listen, thanks so much for inviting me back. Looking forward to having more discussion about hormones.
More discussion.
Yeah,
exactly. So last time we spoke sort of quite broadly, if that's possible, around sort of female hormones, and very much today I'd like to really sort of tap into the sort of the understanding of the misconception around sort of the acceptance of pain with female hormones and cycling, and why we can experience periods that become erratic and sort of variations of cycle lengths, and sort of what we deem to be acceptable or not. And so I think probably an interesting way to frame that first question is pain normal? Is it to be expected when women are having a period? And what sort of level of pain would you consider to be acceptable?
Well, it's very variable. As I always say, every woman is an individual and every woman is different. So how much pain is acceptable or expected? I think it would be unusual, put it this way, to say that a woman goes through her whole life and never has any period pain. And we're talking particularly about pain associated with menstruation, by the way.
Yes.
I think it would be very, very unusual to say that a woman can honestly say, I've never, ever been bothered by it. But so that's on one extreme. But on the other hand, pain that is, quite debilitating in the sense that, literally means the person can't go about their normal activities.
Yes.
It may be that you would have to modify it. For example, if it is feeling uncomfortable, maybe actually you're going to decide that you're not going to do that really hard run. Actually, today, maybe I will just do something like Pilates, by the way, which is shown to help period pain, or swimming or something. So, in the sense that maybe you might slightly modify what you're doing, but it should never be to the extent where actually I can't do anything, I can't go to work. That's the sort of level of pain. So pain, discomfort, that is where you will be aware of it, and you might have to make slight modifications.
Sure.
But it's definitely, not going to literally knock you out. I mean, you can't do anything. and really badly affect your quality of life, that is definitely unacceptable, of course.
Yes.
Right. Well,
No.
only whatever pain we're talking about, by the way.
Yes.
So that's really the guide. If it's a pain that is dealable with, then I think that's that's okay. But I think everyone is individual.
Of
You
course.
see what I mean? So I don't want to sort of say, oh, well, if it gets to this level on the pain score, we have a pain score. It's actually, how much is this affecting your life? And is it affecting your quality of life where actually you can't do the things that you're meant to be doing or want to do? Then definitely that's something you need to be thinking, is there actually a medical reason? Is there something else going on here?
Yes. Yes. So before we sort of go into what some of the underlying causes of that could be, maybe could you, because you so beautifully describe it, could you describe the stages of what a menstrual cycle is, and therefore then the final part that we release these prostaglandins, which sort of cause the pain? Could you beautifully articulate that as the way that you've so
sure. So it's called the menstrual cycle for a reason, because it goes through a cycle comprised of 2 phases, and that sort of repeats. Actually, in technical terms, the beginning of a menstrual cycle is, in fact, the period itself. So you're shedding the endometrial lining. Like we said, there's also the release of the prostaglandins, as you say, inflammatory things. And so that can cause a little bit of discomfort. So that's the menstruation, the start of the period. You're shedding the previous lining, and then now you're starting afresh. Now you're starting in what's called the follicular phase of the cycle, which is when the next egg is being prepared to be released at ovulation. And so that's what the follicular phase is, from the start of the menstrual bleed, that's day 1, and then up until the point of ovulation. Typically, it's the middle of the cycle. And if we're going to just, for maths, to make it simple, let's just say this is going to be day 14. Let's just talk about a 28-day cycle. I know that's not realistic, but just to make the math simple. So typically, the egg will be prepared during the follicular phase. Estrogen, one of the key ovarian hormones, will be rising. And then ovulation, the egg will be released from the ovary and make its journey down the fallopian tube into the uterus, the womb, around about day 14. Once the egg is released, we now move into the next phase of the cycle, which is called the luteal phase. The luteal phase is so named because something called the corpus luteum is formed in the ovary. So the remnants are the surrounding of the egg, that forms a thing called the corpus luteum. And that releases progesterone, which I think many people have heard of as the other big sort of important female hormone released from the ovary. So the luteal phase, estrogen is also still sort of quite high, but progesterone now has its day, or has its 2 weeks, should I say. And so the progesterone goes up, and that can sometimes be associated with things like increasing metabolic rate. You might feel a little bit warmer. That's the point of the ovulation thermometer, for example. And so the egg sort of hangs around for a bit, and the lining of the uterus is also maintained at a certain thickness in case the egg is fertilized, and obviously then goes, pregnancy ensues. If that doesn't happen, the egg isn't fertilized, then guess what? The corpus luteum will degenerate, the progesterone levels will go down, as will the estrogen, and then we start off the next cycle with the shedding of the endometrial lining, and the whole thing repeats. So what I've just described is the menstrual cycle, and this is what most women will experience if they're not taking hormonal contraception, of course, from the age of when periods start. Average age is 12 or so. And this continues typically until the age of menopause, when this whole process stops. Average age 51. So it's a long, it's quite a lot of years. Women are going to have this thing happening every 28 days or so. So yeah, that really sort of, I think, sums up what the menstrual cycle is, what the hormones are doing, and what's happening in terms of, the ovaries and the ovulation and the endometrial lining.
And that would it, and you mentioned that this again, we're sort of generalizing, but so from 12 to, between 12 and sort of 14, 15 is when this begins. And that length of the cycle that is more erratic as at the beginning until someone reaches about their 20s. Is that right? Again, generally. But...
Yes, I'm saying 28 days, but anything between 21 days and 35 days for a cycle is normal.
Yeah.
Okay, so don't get worried if you're thinking, well, my cycle used to always be 26 days as it happened, more or less. So, something within that range. And typically, yes, the first couple of months, they're saying now, after your period start, it can be a little bit more erratic, but the periods should settle down. But if we're talking about erratic, if they are varying outside that range I described of 21 days and 35, so very short cycles or equally very long cycles, even if you're, even if you're a sort of a late teenager, if I can say, I think that also now there's, papers saying that actually we shouldn't dismiss it so much for teenagers. So if a teenager comes in and says, well, actually, I'm only having a period every 3 months or something like this, then actually, again, there might be something going on there. So yes, some degree of variation, especially in the early years, yes, but within the limits of variation, if you know what I mean.
Yeah. Okay, so that's an interesting benchmark for us to sort of to question. So 21 to 35 days ish. And what do you see in your area of work? Again, if we sort of just underpin that in terms of sort of around exercise endocrinology, what do you see are the key drivers or reasons that these menstrual cycles change in length, longer or shorter, Nicky?
Well, in terms specifically of exercise, first of all, by the way, we should all exercise. So I'm not against exercise, just to make that point clear. But on the other hand, like with most things in life, there's an optimal amount for the individual. Okay, so if you don't do enough exercise, that's not a good thing, and actually can sometimes, actually not doing enough exercise and being overweight can disrupt your cycles, as can the opposite end of the spectrum, doing too much exercise, as it were, relative to your food intake. And that's then we talk about low energy availability. So it's the combination of, we have 3 lifestyle choices, behaviors under our control: amount of exercise, amount of food, and amount of sleep and recovery. If you get any of those 3 things, and tripod is a very stable structure, by the way, so that's why it's the 3 things. Anyway, but if any of those things come out of balance, it literally is out of balance. So in terms of the exercise, for example, if you're doing a lot of exercise relative to how much you're eating, i.e. not enough, then you're going to be in low energy availability, and that will impact your female, well, all your hormones, but particularly the female hormones, which can therefore lead to disruption of the menstrual cycles. Initially, the warning sign will be that the cycle length could become very short, because you're not ovulating, or it also could become very long, right? So, but ultimately, what you don't want it to progress to is that it stops entirely, because then we're talking about amenorrhea. So that's the warning sign. But equally, if you're, so it's all about balance.
Absolutely.
That's really what it is. If your periods are really very, like, out of the range of, we said, of variation, very short, very long, then it's the initial thing to do is just have a review yourself of your tripod. Review of your tripod. Is there an imbalance there? And if you have identified that, then obviously try and address that. But also, I think that if at that point also you should be coming to see one of us, to see if there's actually something underlying this medical wise, other conditions going on that could be causing this. But it's because it's a diagnosis of exclusion. There's no reason why you shouldn't get cracking with having a look at your own behaviors whilst you're, sending me a message or whatever, or sending you a message and getting in contact, so we can make sure that this is confirmed, that this is what we're dealing with, and we're not dealing with a medical problem. But I suppose obviously I'm seeing that particular group of women where actually it often turns out that they have got their tripod unstable, as it were. But I would be, it would always, I do a blood test, whatever appropriate blood test, just to make sure that there isn't in the way that we haven't missed a medical thing. Occasionally, very occasionally, there is something that comes up that, actually it is a separate medical issue that needs addressing. But also, if we come to the conclusion, actually, it is that imbalance of behaviors, then obviously it's easier to give more specific, personalized recommendations for that woman.
Absolutely. That segues so beautifully into, I also use, I have a triangle that I show my clients as well. And it's, and the brain is at the center of the triangle, and it's showing the ovaries, the thyroid, the stress glands. And if any of those are off, because the brain is continually monitoring the environment, those behaviors, the circadian rhythm, the food intake, the stress level, which extreme or lack of exercise is one. So it's about it's whatever the tripod or the three-legged stool is. Yeah, it needs three legs.
But I think you make a very good point that we have evolved. We've got an excellent, brilliant internal monitoring system.
Amazing.
You see, the brain, like you said. Well, in talking about hormones, the pituitary gland specifically is the boss, is the conductor of the endocrine orchestra, as I always say, So that is the literally the control center. And so we can getting in tune with our bodies and noticing things, for example, women period, just like, why is this changing? The body is trying to tell you something. So use your own internal monitoring system, and then we can help with getting the details of that with the blood tests and looking at the hormones, what they're doing.
Perfect. Brilliant. Going back to food, whether it's restriction or whether it's excess, but of course both of those are stressors to the master controller that you've just alluded to. But there are also what we call sort of specific micronutrients, so vitamins and minerals that the entire body's biochemistry depends upon. But as specific to hormones, there are some really important ones around that whole cycle. And so would there be some, it's difficult, I know, are there some standout nutrients that you both assess for and consider in this type of work?
Yeah, I would always test the hematinics, the things that are required to make red blood cells. So iron status, ferritin, B12, folate. Because although I'm saying they're very good for making red blood cells, actually, like you say, these vitamins and sometimes the minerals are, very important for enzymes. They're coenzymes. So the enzymes, by the way, what are enzymes? They're biological catalysts, right? And so, if you haven't got a bit of the cog, right, a spoke's missing or something, then obviously it's not going to work very well. So that's what vitamins and minerals are important for. You don't need a lot of them, but you definitely need them. So I always test for those things. I also, interestingly, test for vitamin D, which is vitamin D actually, of course, it's a pro-hormone. It's actually a hormone, not a vitamin.
I know,
right? I know. And
yeah,
exactly.
We're going to rename it a hormone.
I know. I want another hormone here. Anyway, but vitamin D is a very interesting one because it actually works in synergy, so in partnership with sex steroids, for example, estrogen. So, again, it's got a direct, working relationship, if I can put it that way. And certainly we know that from studies that vitamin D is often recommended to women who have problems, for example, during their luteal phase with the high progesterone levels. That's one of the few things that is recommended. Well, when I say one of the few things that's proven to be helpful from the Royal College of Obstetrics and Gynecology, have a very useful table saying what does and doesn't work, and vitamin D is the standout one that does. So if in doubt, of course, have a good diet, a range of diet, etc., what you're eating. But vitamin D is also unusual in that you can't get all your requirements from the diet alone. So again, another reason we should call it a hormone, by the way. It's not to do with the diet. We can't, even if we eat a lot of dairy and oily fish, we can't get our full requirement from diet alone in terms of vitamin D. It's the action of sunlight in the skin and looking out the window. Actually, today it's sunny, but as a general, exactly. As in England over the winter months, Public Health England recommend we all take vitamin D anyway. Personally, I take it all year round, but definitely that's something that can easily get overlooked because people don't realize, like you say, the sun isn't strong enough in England, and even if you were to walk around naked all over winter, good luck. It's not a medical recommendation. That
well, it might be quite good for our vagus nerve,
because although you will get you will get a little bit more sun, but even if you did that, you still wouldn't get enough sunlight on your skin to make vitamin D. So it's not a recommendation, you'll be pleased to know, right? Okay. So just get the supplementation instead, especially over the winter months. And also vitamin D, apart from being vital and helpful for hormones, of course, bone health, immunity, and actually well-being. Lots of people, over the winter feel a bit down, and actually now we know that quite a lot of that, or contributing factor certainly, is low levels of vitamin D. So if you're going to buy anything, definitely worthwhile investing in vitamin D supplements.
Yeah, I couldn't agree more. And I noticed that, and time and time again, that when I test it, and I use Forth when I test vitamin D, and it's one of the first interventions, and time and time again people say to me, goodness, my mood is so much better. And it's actually quite fast acting.
Oh yes, it is. Yes, so definitely very, very worthwhile, not expensive.
No.
And medically proven that it's beneficial. So why not?
Yeah, absolutely. So vitamin, and then as you called it, the hemogenic vitamins, so iron, which most people associate anemia with just iron, but we have to consider B12 and folate, which we get from green leafy veg, but sometimes we don't get enough, and so that's definitely worth considering.
For sure.
Great. Okay. So, and is there with vitamin D, you referred to the fact that it is far-reaching and that it also impacts positively the immune system. And there are a number of conditions, if you like, that you alluded to, that we might then want to, we would want to rule in or rule out as being contributory to somebody's health. So conditions such as endometriosis has hormones. I think hormones are at play in terms of mediating that type of condition, but it's essentially an inflammatory condition. So, and there is the immune system is woven into that pathophysiology.
Good point. Yes. So endometriosis, what that means is that it means tissue that is sensitive to female hormones, which is outside of where you would expect, as it were. So obviously we've just said that the endometrium, the lining of the uterus, is obviously sensitive to hormones because the uterus thickens and then it's shed, etc. So that's fine. That's where it's meant to be. But if there is that type of tissue is outside of where it's meant to be, then for example, bowel, bladder, something like that, then that's going to be a problem. So and also you said that that's what endometriosis is: misplaced tissue that's sensitive to the female hormone. But that's why female hormones are the drivers behind the condition, because now you've got this tissue which is sensitive to these hormones outside of where it's meant to be, And then when the hormones go through, like we discussed at the beginning, there's cyclical change during the cycle, then lo and behold, that's going to cause problems. And so this is typical. So the presentation of endometriosis is, really high levels of pain, unacceptable in the sense that it does interfere with your quality of life, with what you can do. I've seen women, it's dreadful. They really, when people talk about period pain, a bit discomfort, this is something different. I mean, you cannot move, and you're being sick and it's dreadful. And every time you try and go to the toilet, it's really, really painful and all this sort of thing. But the reason why it's so difficult to diagnose, therefore, is that when push comes to shove, it is on the clinical history. This woman saying that she is in really bad pain. But again, because pain is such a difficult thing to quantify, we have pain scales and whatever, and then women often get told, oh, well, it's normal for women to experience pain. Well, not pain to that extent that it decks you. So that's one reason. And also women, we're quite resilient. We try and soldier on and try and say, oh, well, maybe you question yourself. Maybe I'm making too much of this. And, maybe I should just try and get on with it. So I think that's the reason. The pain is the main symptom, because really, if you want to make a proper diagnosis, you actually have to get a bit of tissue. You actually have to look inside the person. And obviously, it's not a simple test, shall we say. It's so that is one of the problems. But I would advise that if you're a woman listening to this and you are getting a lot of pain, then actually write it down, document it, okay? Because then when you keep a pain diary, as it were, because then when you do go to a doctor, you can show them the evidence rather than just sort of vaguely saying, oh, I get a lot of pain. Actually showing them, look, I made the effort to write it down and really, be honest, say, right, the pain was so dreadful, couldn't get out of bed or whatever, I couldn't go to work or something, say what it is. Keep a diary of that and then take that with you. And then that will hopefully help you, get something done that's going to help you identify what's going on.
Perfect. Great advice. So with that specifically, we're saying that there are, with endometriosis, there are these endometrial cells in places where they shouldn't be. So they're growing in the pelvic, or they're in the pelvic cavity, in the bladder, on the ovary, and then there is a hormonal mediation part of it where we know that estrogen, as you described at the beginning, is about growth and proliferation. So which is what estrogen is designed to do. So it just becomes a vicious cycle.
Yeah.
Sort of managing it or looking at it maybe in a broader picture in terms of also recognizing that there's an immune component to it as well. Is a place where we could help and look at that in a slightly broader lens.
Yeah, like you said, you're absolutely right. The inflammatory process, the immune response to this is very important. So I've described what happens, but you're right. There are cells in the wrong place, etc. Sensitive to the ovarian hormones, but then so what? But then because the body is like, well, what's this doing here? And it gets in a bit of a flap. And so the immune cells get sent in, and inflammation is really, really useful. In some situations. Inflammation, for example, I've got a scratch here. All right. So I want some inflammation there. Thank you very much. I want some white cells in there. I want some to get rid of any infection. I want that dealt with. Thank you very much. But it's when it then carries on, self-perpetuates, because it's a sort of cascade thing. So in the situation of endometriosis, an initial bit of inflammation might be helpful, deal with it, but then it just gets carried away. And so it escalates. So yes, sure, looking to ways that could support the immune system or keep it in, modulate it. Thank you. That's the word. That's the thing that can also help, although it won't sort of, make those cells vanish, but it would certainly maybe help, like you say.
Okay, brilliant. Thank you. One of the other conditions that is very common and maybe maybe not quite fully understood is PCOS as well, which is what do you see? What is going on from a physiological perspective with that condition?
Yeah. So PCOS stands for polycystic ovarian syndrome, although we come to a slight stumbling block even with the name.
Yes.
Because it's not actually correct.
Yes. Well,
we're not talking about cysts on the ovaries, by the way. We're talking about follicles, the developing eggs. So anyway, but why that's important, I'll come to in a minute. So what happens there? There, it is a mistiming of the hormones. Okay, so I've described to you already the nice cyclical variation of the hormones, but what happens in PCOS is that these hormones get out of sync. Now, the honest truth is we don't know why that happens, what triggers that, why do they get out of sync? There's all sorts of theories. Maybe it's partially genetic. I think it is. All sorts of other. But anyway, what is the mistiming I'm talking about? So when the egg, if we cast our minds back to the follicular phase, of the cycle, when the egg is being prepared for ovulation, what happens is that normally there is a little bit of testosterone. The testosterone goes a little bit higher towards the end of the follicular phase in preparation for ovulation. But in PCOS, the testosterone gets carried away. It keeps being secreted, okay? And this messes up ovulation. And so the pituitary gland is annoyed and keeps sending out lots of LH, luteinizing hormone, to try and get the egg to ovulate. But it won't. It is kind of blocked, okay, because of this high testosterone, okay? And so women with PCOS typically, they don't ovulate. And the strict definition of how do you diagnose that a woman has PCOS is based on 3 criteria, the so-called Rotterdam Criteria, and you have to have 2 out of the 3. The 3 criteria are irregular cycles or missing cycles, okay? So outside that range that we discussed.
Yep, great.
Biochemical or clinical evidence of the high testosterone. I mentioned testosterone already. Yep. So that means that on a blood test, you see the testosterone is high, or clinical evidence. In other words, unwanted hair growth on the face or elsewhere, or a lot of spots.
Yeah.
This is, by the way, where sometimes it gets a little bit, because lots of teenagers are going to have this, by the way. Anyway, I mean spots anyway. But anyway, so irregular periods, the testosterone, and the third one is on ultrasound. You see lots of follicles, multiple follicles. They're not cysts.
No. And let's just so the reason that we see lots of follicles is because the brain is
exactly. It's got out of sync. Like I've said, it's got out of sync. The eggs aren't being ovulated.
Yeah.
But the ovary is getting annoyed, and it's trying to make them to be ovulated. Come on, get your act together. So the eggs, so they're trying to do their best. They just get to a certain stage and they stop. So that's why you see lots of them hanging around, milling around, right?
Yeah.
But so that's why you see that. So you have to. So in order to diagnose PCOS, you have to have 2 out of those 3 things. Okay, right? So that's what it is. But so that sounds straightforward, doesn't it? Let's do those three things, and then voila. But the only problem is that it's very easy for people to say, busy GPs to say, oh well, the woman says I've got irregular periods, and because it's true, PCOS is quite a common condition. It's one of the most common endocrine conditions. To automatically assume, oh, this is PCOS. Right, and that's it. You need to go on the pill, etc., etc. But actually, if you dug a little bit further, you would find out that actually, on the clinical history, this is not PCOS, because actually they're one of these women that has doing excessive exercise relative to what they're eating. And this is why their periods have become irregular. If we go back to the very beginning, why do women have irregular periods? So actually, this is the complete opposite of what a woman with PCOS has, because PCOS also has a metabolic component. It's not part of the diagnostic criteria, but we know that a woman with true PCOS, according to that Rotterdam criteria, will also have insulin resistance. Again, one of these things we don't exactly know, chicken and egg. Was it the high testosterone caused insulin resistance? Was it the insulin resistance that messed up the testosterone? We don't know. But suffice to say, they all hang out together. And so the woman, so insulin resistance is often the precursor to type 2 diabetes, by the way, okay? Yeah. I'm not saying that every woman with PCOS will get type 2 diabetes. I'm just trying to put it into context. What do I mean by this word, insulin resistance, okay? So that's what it is. So PCOS, it's a common condition, but just make sure if you're a woman that's been told, oh, you've got PCOS, just make sure that it's according to what I've just said, those criteria. Or have you been just gone to the GP and said, I've got irregular periods, and have you just been told, oh, you've got PCOS? Have you got evidence from the blood test with the testosterone being high? And actually, is your clinical history also consistent with PCOS and not with someone who's got low energy availability? So just, check your own facts, right? You're the one that knows your own facts probably better than anybody else. So just be aware. If it is true PCOS, what are you going to do about it? Depends on the woman. If her main issue is that she's feeling the effects of testosterone in the sense that she has got unacceptable hair growth and bad skin, just is not happy from that point of view. And because she's not ovulating, then the estrogen is going to stay high. And actually, there's a thick endometrial lining. Yeah, we want to give her endometrial protection, as we say, because too much of any hormone is not a good thing, including estrogen. So in that case, if that's the woman's main problems, then actually the contraceptive pill is a good choice, because the contraceptive pill will lower the testosterone levels and will suppress the hormones and actually cause a regular withdrawal bleed. So that's for that sort of woman. If the woman is saying, well, actually, my main objective is I want to get pregnant, then obviously you're not going to put on the pill. No. All right. That would be a different course of action. You're going to look, is she ovulating? If she isn't, then it would be in case of some medications to encourage ovulation induction, as we say. So it very much depends on what the woman wants. Yeah. Right. Some women actually have PCOS and it's very mild. And there is actually an argument that some of the top elite athletes have got PCOS and they're very happy. Thank you very much. Because testosterone, having a slightly higher testosterone level might give a competitive advantage, for example.
Wow, how interesting.
You see, there are some studies saying that. So, it really depends on what symptoms you're getting from the PCOS. I think from a medical point of view, the only concern we would have as a doctor, where we would say, actually, we need to do something, is if the woman has PCOS and hasn't been having periods, and actually her endometrial lining is really, really thick. Okay, absolutely. So that would be the thing when we'd say, I'm sorry, but we got to get a withdrawal bleed here. And so actually might give them some progesterone so they can shed that lining from a medical point of view. But otherwise, it's entirely up to the woman what she wants to do about it, really. But that would only be the medical proviso.
Fascinating. I've never heard it from that perspective, obviously, because of your area, particular area of expertise, or the whole endocrinology is your area of expertise, but that particular focus with professional athletes or athletes and exercise, that, of course, the testosterone, that's a whole other that's a whole other discussion for another day. But I've just had to do a review of the literature because I'm doing a presentation at Barca Football Club next month. So I was just looking at that. I'm not entirely, I have to be honest, I'm not entirely convinced by that, but it's a possibility that some of the more power sports
maybe there are, or maybe it's a selection thing. That's why they choose those sports, because they have PCOS. See, so anyway, but that's definitely, it's just an interesting.
It is really interesting.
An interesting thing, but ultimately, it's kind of in some ways down to the woman, depending on what she wants with that medical thing about.
Yeah.
If the endometrial lining is too thick, it's like whatever she wants.
Yeah,
we need to get shed that.
We can't have that.
But otherwise, it's very much what the woman wants. And also going back to my other thing at the beginning, that we are talking about someone who definitely has PCOS. Because the other thing I see is lots of women who have been labelled as, oh, you've got PCOS, and bunged on the oral contraceptive pill, when actually what was happening was what's happened is that not many people have read the small print for the Rotterdam Criteria. The Rotterdam Criteria is straightforward. You need 2 out of 3, but then in small print, well, not that small print, underneath it says, in the absence of any other condition which could give you multiple follicles. And one of those are being an adolescent, which is why many of us are not in favor of giving adolescents the contraceptive pill. And also the other condition is weight loss and then weight gain. So you go into reds, low energy availability, your periods might stop. And then as you're trying to get them to start again, guess what? It's like being a teenager again, because the hormones have got to learn their timing. And I said at the beginning, it's about mistiming of the hormones. So that's a very common situation where actually there are some multiple follicles. I can't deny that. And there might even, testosterone might even be a little bit high because it's trying to get rejig, retime, rebalance, whatever. So, just a few little caveats there.
That's really interesting.
To PCOS, it has, as with everything, it has to be in the clinical context of the person. If you've got a teenager in front of you, then guess what? It's more likely because they're a teenager. If you've got an athlete in front of you that you're trying to coax out of relative energy deficiency in sport, then most likely it's not PCOS, it's just a PCO. Polycystic ovaries. I still don't like cystic word, but anyway. It's not the syndrome that I've just described. It's just, yes, there are follicles, but not for the reason, but it's for a different reason.
And then if we, for the, I don't want to call you listeners average, but that's the terminology. But for the above average woman,
well-informed
listening, yes, well-informed, that's the word, woman listening, just to the building block of the beginning part of the cycle is testosterone. And if the brain, if that triggering hormone, GnRH, is not firing properly, then that is what can cause more of that testosterone production. So it's
a vicious circle. It's a vicious circle because the whole hormone system is based on feedback. So if the brain, if the pituitary and the hypothalamus is probably even top level, or the pituitary, if the hypothalamus and the pituitary are not getting mixed messages, literally, then the whole feedback loop gets a bit, disrupted. That's why I called it a mistiming. The whole thing is just not firing correctly, you see?
Yes, perfect. So I think that's probably a really good place to close that off in terms of what we're sort of saying. We've spoken in depth about a lot, as always. But really, I love your tripod analogy, and I use this, and in fact, I did a post yesterday about stress and how that miscommunicates then across all of our systems. And what we're saying, and really, is that we need to be continually monitoring and being responsible for our own body's health. The body is incredible. We need to honor it. We need to respect that triangle.
Yeah, well, tune into it. So number one, you tune into it, and I'm a great fan of writing things down. Doesn't have to be, I know there are lots of apps and I don't know what, but good old-fashioned pen and paper never harmed. So just tune into what's going on for you. You know what's normal, you're the best. You control your own data, right? You know what's going on for you, and if things are changed for you. So just be aware of that. Don't try and ignore it. Just question it, wonder, just explore it, see what's going on. You can do a lot of detective work just based on that for yourself. But then ultimately, yes, if you're saying, well, actually there is something that's changed here and I can't figure out why, there isn't an obvious reason, like I'm feeling very tired this morning because I just had a stressful flight on the way back and I had to run to the terminal. Anyway, what I mean? If there's or we'll try and address it if you can identify it. But if in doubt, then of course, get some blood tests, get down and see, use this amazing system, tap into it. Let's see what's going on and what needs to be addressed.
Brilliant. Nicky, thank you. And just to sort of finish up there, Nicky and I have both talked about sort of the importance of taking a really good case history, but it's also important to rule in or rule out certain pathophysiology or contributing factors. And this is where Forth with Life, or Forth, you can find them at forthwithlife.co.uk. They run home blood testing, and the beauty, because Nicky is the Chief Medical Officer, when we're measuring hormones, they are being measured at the right time of the cycle. So there is a female mapping product, which is assessing estrogen at the peak, which is around day 14, and progesterone sort of after ovulation. So it is a highly, really, really useful test, which I'm getting all of my my menstruating female clients to do, and it's fantastically useful. So you can find Nicky, consult with her as well independently. Her website is Nicky Keay, Keay, fitness.com. And forthwithlife.co.uk. So really fantastic to have you here, and start of a lovely relationship, hopefully.
Yeah, no, lovely. Thank you so much. I always love discussing stuff with you. Thank you so much.
You too. Thank you so much. Thank you for listening, everybody, and we will see you again really soon.